we start anatomical basis for middle metal sinusotomy or antrostomy. And in this part of surgery, we do uncinectomy, not total uncinectomy, but uncinectomy for the portion of the uncinate related to the maxillary sinus natural ostium. And with the help of computer software like OsireX and the use of multi-detector or multi-slice CT scan thin series, which is usually less than 1 millimeter in diameter, this file can be projected axial, sagittal, and coronal cuts in a high resolution with multiplanar reconstruction, which is very important for the orientation or the knowledge or the appraisal of the anatomy of the sinonasal tract. Here is the multiplanar reconstruction with OsireX, and here is the natural ostium of the maxillary sinus high up in the maxillary sinus. This is the uncinate process, and here is the ostium. This is the inframedial orbital wall. And on sagittal cut, we see the ostium here in intimate relation to the nasolacrimal duct here, and it is also in the anterior part of the maxillary sinus. So the ostium is in the anterior and superior part of the maxillary sinus, like here and there. Now, this is the multiplanar reconstruction, and as I said, this intersection is the same point on sagittal, axial, and coronal cuts, and by grasping one of them, I'm grasping here the coronal intersection and moving to visualize the ostium on the sagittal. And now I'm moving along the uncinate process superiorly here, and then look for the sagittal cut. This is the uncinate process as I am moving the intersection on the sagittal and look for the coronal. It forms the posterior wall of the agar-nazi cell. This is an agar-nazi cell, and through the agar-nazi cell, it is inserted in the lamina paprasia. So simply, if we follow the uncinate process superiorly like that, then we can reach the frontal sinus easily. Following the uncinate superiorly will lead us or guide us to the site of the natural ostium of the frontal sinus. And here is the bulla, which is rather large bulla reaching the skull base, and within this large bulla one can expect to find the anterior ethmoidal arch. I'm moving to the left side also to the area of the maxillary sinus ostium and going with the uncinate till we reach the posterior part of the agar-nazi cell on the sagittal section here, and if we go up we can reach the frontal sinus. Now, because I'm familiar with this multiplanar reconstruction, I know that this is the anterior ethmoidal artery, and it is running here in mesentery because there is supraorbital pneumatization. So this is the anterior ethmoidal artery, and because the bulla ethmoidalis is reaching the skull base, it's actually inside the bulla ethmoidalis. And as you can see on the this sagittal cut, it runs in the floor of the supraorbital pneumatization. In a cadaver, fresh cadaver like that, this is the ethmoidal bulla, and here is the uncinate process. And in this cadaver dissection course, I dissected the uncinate submucosally to give the audience an idea about how large the uncinate is. So if we remove the mucosa like that, this is the uncinate process, and here is the uncinate as a sheet, and this actually part of the uncinate because the uncinate has still superior attachment and more posterior attachment. So after removing this uncinate process, this is the inner layer of the lining of the uncinate process, or the infundibular lining of the uncinate process. And if we fenestrate this area, we will get a large, what one can say, middle metal antrostomy. But look for here, because this is a 30-degree angle endoscope with the angle of the endoscope at 11 o'clock. And if we move this angle to 9 o'clock here, one can see the important structure which is the natural ostium of the maxillary sinus. So again, this is the angled endoscope 30 degree, and here is the natural ostium of the maxillary sinus. This is the fenestration I made, and here is the inframedial orbital wall. In order to have a proper middle metal antrostomy, one should connect the natural ostium with this posterior fontanelle window, and by cutting this part of tissues to ensure that the middle metal antrostomy is including the natural ostium here. Let us see this in a patient. Here is the ethmoidal bulla, the uncinate process and polyp at the expected area of the natural ostium. And what are the landmark for the natural ostium? It is behind the uncinate process, hidden by the uncinate process. You can't see it easily except with the 70-degree angled endoscope. The natural ostium lies at the horizontal level of the inferior border of the ethmoidal bulla, and one should expect that the ostium will be in this area. Let us see this patient. This patient has concha bullosa, and after resecting the lateral part of the concha bullosa, one can see the uncinate process and the ethmoidal bulla. There was some polyps in the frontal recess here, and here is the ethmoidal bulla. This is the uncinate process, and if you deliver the uncinate process anteriorly, you can see the polyps narrowing the natural ostium. The best way to do middle metal antrostomy is to use the backbiting forceps, because it is neat and you dissect what is important, and the sickle knife is not good. And here is the natural ostium of the maxillary sinus. After seeing the natural ostium of the maxillary sinus, one has to make the antrostomy starting from the anterior, going posteriorly and inferiorly. I delivered here the uncinate medially, but now it's better to make a snip at this area to prevent herniation of the roof mucosa of the antrum. Then we resect the uncinate posteriorly and inferiorly using shavers or through cutting forceps until we create a middle metal antrostomy of suitable size. The size is more with fungal disease. Now here is the natural ostia area with some polypoidal mucosa. The remnants of the uncinate should be removed clearly around or near the area of the natural ostium, and then these polypoidal mucosa or sessile polyps have to be excised with shavers or with curved instruments like the Weiser forceps here. This is a retention cyst in the lateral wall of the maxillary sinus, an innocent pathology, but the polypoidal mucosa near the ostium is more important and should be removed, because the most functional area in middle metal antrostomy is the area where the natural ostium is. One should clean this area cautiously and have this view at the end. Now we stop here. For the second video is for anatomical basis for frontal sinus.